Today I will be discussing persistent complex bereavement disorder, alcohol abuse, and benzodiazepines. Throughout this presentation, I will be discussing how diagnosis and treatment for persistent complex bereavement disorder and alcohol abuse. I will then explore how these two diagnoses co-occur and how benzodiazepines can be used for treatment but also can interact with alcohol. Next, we will look at a case study to explore the treatment of complex bereavement disorder and alcohol abuse. Persistent complex bereavement disorder is currently only a proposed diagnosis in the DSM-5. This proposed criteria for diagnosis is death of someone close to the client, experiencing one of these symptoms for most days within a year, yearning, longing for deceased, and intense emotional pain, preoccupation with deceased, and preoccupation with circumstances of death, and then 6 symptoms on most days for a year, such as difficulty accepting death, the disbelief or numbness, difficulty with positive reminiscing, anger related to loss, maladaptive about oneself, excessive avoidance or reminders of loss, a desire to die to be with the deceased, difficulty trusting others, feeling alone or detached, feelings of meaninglessness and confusion about one's role, and a reluctance to pursue interest, along with clinical significant distress in social, occupational, or other important areas of functioning, and a reaction that is out of proportion or inconsistent to culture, religion, and age-appropriate norms. Currently, complex grief would be diagnosed under other specific trauma or stress-related disorders. Complex complicated grief is also referred to as complicated grief or prolonged grief disorder in some literature. However, all of these terms describe failure to transition from acute grief to integrative grief. Statistics of complicated grief vary, but it can occur in 2.4 to 20% of bereaved individuals. Benzodiazepines can be commonly prescribed to about 9.3% of the bereaved for complicated grief due to the relief of distress and aiding in sleep. However, the use of drugs can inhibit normal grieving and be a gateway for long-term use, which will be discussed later in the presentation. Antidepressants can also be a pharmacological treatment for grief. Treatment for persistent complex bereavement disorder can include cognitive behavioral therapy, which is shown to be an effective treatment for complex persistent grief by focusing on exposure, cognitive restructuring, and social sharing. CBT has also been shown to be beneficial for treatment for PTSD, which shares similar criteria as persistent complex bereavement disorders, such as intrusive thoughts and avoidance. Studies showing improvements in interpersonal relationships and maturity for mothers who have experienced prolonged grief after losing a neonate. Narrative therapy is another treatment that can be used for complex persistent grief. There is a variation in research regarding alcohol abuse and bereaved individuals. However, an increased risk of alcohol abuse can be predicted due to the tension reduction hypothesis. Research has shown that substance use can be exacerbated based on grief. 71.7% of those facing complicated grief have multiple diagnoses, and 3.7 were found to have some level of alcohol abuse. There are several options for screening tools for alcohol abuse. One of those is the Michigan Alcohol Screening Test, or MAST, an alcohol use disorder identification test, which is also known as AUDIT, or the Alcohol Use Inventory. Alcohol is considered a depressant. It depresses the central nervous system, which helps to promote relaxation. But alcohol is also a neurotoxin, which can lead to damage to brain function. There are several models of addiction. One is being the disease model, where addiction is the primary disease, is progressive, and once an individual starts the process of the disease, and when they drink alcohol again, they will encounter problem behaviors. There's the genetic model. The genetic connection to alcoholism, a scientist has proposed several theories due to the metabolic defect, or impaired production of enzymes in processing the alcohol, or a deficiency in vitamins that lead to cravings of alcohol. And then the neurobiological model. When a person begins to drink alcohol, changes in brain chemistry occur, which leads to addiction. According to the DSM-5, there are several alcohol-related disorders. The criteria for alcohol use disorder is a problem pattern of alcohol use within a 12-month period, leading to significant impairment. To fit the diagnosis for alcohol use, 2 of the following symptoms has to be met for mild alcohol abuse, 4 to 5 symptoms for moderate, and 6 or more for severe alcohol abuse. The symptoms are alcohol being consumed in large amounts for longer periods of time than intended, unsuccessful efforts to control alcohol abuse, spending a large amount of time to obtain, use, or recover from alcohol, craving or strong urges for alcohol, alcohol use causing failure to fulfill obligations, a continued use even when causing social and interpersonal problems, other activities being given up or reduced because of alcohol use, continued use even though the problem is exacerbated from use, and building a tolerance shown by increasing amounts to achieve intoxication or little effects with the continued use of the same amount, along with withdrawal symptoms. Also, alcohol intoxication and withdrawal are recognized by the DSM-5. It is important for counselors to understand the trends and special needs of different populations. When it comes to alcohol use, bereaved men 2 years following the death are more likely to have alcohol-related problems. Women are less likely to seek treatment for alcohol abuse due to social stigma. However, that trend is changing. Women are also vulnerable to alcohol-related problems with a lower consumption rate due to their body weight and metabolism. Children of alcohol abusers often experience more negative emotions such as sadness and anger. Youth and young adults who drink are at risk for death and injury, along with other consequences, and being at an increased risk for binge drinking habits. Trauma can also increase the amount of alcohol consumption. Youth who lost a parent to suicide and those who have faced sudden or violent losses are at an increased risk. Culturally, whites begin drinking earlier and progress quicker to alcohol dependence, but Black and Hispanics are more likely to have alcohol-related mortality and are less likely to seek help. Benzodiazepines can be used to treat seizures that occur with alcohol withdrawal. However, this drug can be lethal when mixed with alcohol. Naltrexone and acamprosate are other pharmacological agents that can be used to treat alcohol abuse. There are many different treatment options for alcohol abuse. As mentioned when we were discussing population, alcohol abuse impacts the whole family. Marriage and family therapy can be beneficial, along with CBT, self-help groups or 12-step facilitation, and motivational enhancement therapy. Marriage and family therapy is a treatment option. It's based on symptoms theory approach. The families are viewed as a system, which they find balance or homeostasis through boundaries and individual members' roles. Addiction disrupts this homeostasis, causing inflexibility or disconnect between the boundaries and rigid roles. Treatment for the environment, which includes creating safety for the family, and each family member tells their story of trauma for other family members to hear their perspective. The system phase is a working phase to repair disorientations of reality and challenges rationalization that supports the old rules in the individuals. Cognitive behavioral therapy is another option for treatment. It begins with an analysis to identify beliefs, attitudes, and situations that contribute to the patient's alcohol abuse. Cognitive behavioral therapy can address coping skills and emotional interventions to help the client regulate their emotions and not serve as a trigger for relapse. Also, CBT can be used to teach the client to modify their thoughts and choose alternatives to drinking when cravings. A 12-step approach or self-help, such as Alcohol Anonymous, follows 12 steps that the client works through in which they admit that they are powerless over alcohol. They rely on God or spiritual awakening. They admit their wrongs and make amends. Participation in these groups are typically voluntary, but the counselor can help clients process and reflect on their group experience and practice the new skills. 12-step programs such as AA provide support for recovery, reducing a sense of isolation, and helping clients develop a sense of self-regulation. Motivational interviewing is another approach that's based on a relationship-centered, client-centered system of change, where you acknowledge where the client is in their set of change and use techniques such as open-ended questions, reflective listening, affirmation, summarization, and holistic change talk to help them make change. Co-occurring disorders are when two disorders, such as substance abuse and mental health disorders, which are not part of the same cluster of symptoms, occur at the same time. For example, have we been talking in this presentation about alcohol abuse and chronic grief. Grief is not something that has a linear timeline. 71.7% of the study's population has co-occurring diagnosis with complicated grief, PTSD, panic disorder, bipolar disorder, alcohol abuse, generalized anxiety disorder. There's an increase in depression, substance abuse disorders, and an increase in risk of mobility for bereaved. Attachment anxiety has also been linked with higher levels of prolonged grief and has shown association with attachment anxiety and alcohol abuse. Also, previous history of psychiatric or abuse increases the risk of that reoccurring during a bereavement. When screening and treating co-occurring disorders, the Brief Grief Questionnaire was developed. It's a 5-item scale that's been developed for screening for complicated grief. The screening tool is relatively still new and only validated with Asian population. More research should continue before this is regarded as a tool. According to Midkoff, when mental illness and substance use disorders are comorbid, both disorders should be considered primary, and treatment of both should be integrated and simultaneous. Integrating interventions should be matched based on the stage of change for each diagnosis. For example, a person might be in an action stage for their mental illness, but a contemplation stage for their alcohol abuse. These stages of change should be considered before making the final treatment. As mentioned previously, as treatment for complicated grief and alcohol abuse, benzodiazepines are classified as a minor tranquilizer. Common names for benzodiazepines are Valium, Xanax, and Librium. These drugs are used to decrease anxiety and panic attacks, induce sleep, control seizures, and treat epilepsy. And it also uses muscle relaxers to treat muscle sprains, MS, and Parkinson's. However, benzodiazepines are now known to be addicting. The increasing risk of overdose when taken with alcohol or barbiturates and can make those with pre-existing liver, kidney, and heart damage more vulnerable to organ failure and death. 15 to 44% of long-time users become addicted. Benzodiazepines can also increase appetite, causing weight gain, and reduce REM sleep. As mentioned previously, benzodiazepines should not be taken with alcohol or barbiturates. A physician who is educated in drug interactions and the effect of the grief process should be the one prescribing this drug. Now we're going to look at a case study to explore more of the treatment options for chronic grief and alcohol abuse. Jack Johnson's a 14-year-old Caucasian male who lost his wife Jane 2 years ago to a murder. Jack sought therapy due to his grief. He has and preoccupied with the circumstances of the death, daily reliving his wife being murdered, continues to act like his wife is alive, and continues to be angry with Jane for being in the wrong place at the wrong time, and not able to have any reminders in his home of her, and gets angry when his son asks about her. He's not able to care for his son, who has now gone to live with his extended family, and he has feelings of wanting to die to be with Jane again. Jack drinks socially before Jane's death. However, he's turned to alcohol to numb his feelings since he consumes more than he intends to, and when he has attempted to stay sober, he has done so unsuccessfully. He continues to experience strong cravings. His drinking has also led to him not being able to care for his son, and he has missed work obligations due to being hungover. When diagnosing Jack, he would be diagnosed with other specific trauma and stressor-related disorders, but he fits criteria for persistent complex bereavement disorder because of the death of a spouse, having preoccupation with circumstances of death on most days for a year, along with difficulty accepting death, remembering Jane positively, feelings of anger, avoidance of reminders, and being detached from his son, and a desire to be with Jane. We'd also diagnose him with moderate alcohol abuse disorder because he fits 4 of the symptoms, such as alcohol being taken in larger amounts than intended. He's tried unsuccessfully to cut down on his alcohol use, experiences cravings for use, and recurrent alcohol abuse, which has resulted in unfulfilled obligations at home and sometimes at work. Using a theoretical approach, it's based on co-occurring illnesses of complicated grief and alcohol abuse. Choose to use an integrative approach of attachment theory, focusing on secure attachment with others, which is shown to be helpful in coping with bereavement. Motivational interviewing to recognize Jack's stage of change for his complicated grief and alcohol abuse, and tailor the treatment accordingly. And using cognitive behavioral strategies to help change thought patterns and promote healing from both illnesses. Looking at a treatment plan, it would consist of a 12-step facilitation or self-help group to provide attachment with others and support for his addiction, along with using cognitive behavioral strategies such as alternative coping and narrative therapy to promote assimilation of the loss into his life narrative and find meaning in the loss of his wife. Thank you for listening to our presentation.